Yes, it's
Yes.
fine. Nice
Wonderful.
to meet you.
Thank you very much, Professor Kurisheva, for your kind invitation. Hello, everybody. I'm very happy to be with you today. And as I understood from the introduction, that this symposium is the follow-up action in the context of 3P medicine following the huge congress of EPMA, which took place in Shantou and China and Perth, Australia this year in September, which collected more than 5,000 participants. So Professor Kurisheva was representing the National Committee of the Russian Federations and of the Department of Ophthalmology within the EPMA working group, which she is the leader of. So I'm happy also to see our Chinese colleagues from Shantou. Hello to you. I hope that you will provide my greetings to everybody in Shantou. Till now, we are still impressed by your wonderful hospitality. Thank you again. I think that this huge congress, which was also broadly commented in the Chinese television, was possible due to your fantastic organization, due to your fantastic hospitality. Thank you very much. So today I have a very tough task to talk to top professionals in ophthalmology, convincing you that the clue to the success of systemic disorders like glaucoma is indeed in multidisciplinary cooperation. It is very important to stress this to understand also why so many PPPM is in the title and in the name of the association. You can imagine that that to be personalized means first to learn as much as possible about the patient. It means individualized patient profile. To be early enough in diagnostics, we need the predictive approach. And finally, to be cost effective, we need to provide of high quality primary care and targeted prevention. So this is very complex, and let's go step by step. I would like to ask you to open the slides to discuss what are the main points of PPPM and what is the message from the EPMA to you ophthalmologists, to you top people in glaucoma research and management. So again, today I am presenting the association, which is the umbrella of 56 countries altogether in all continents around the world. This is a huge professional network, and our main instrument is the EPMA journal, which is the leader in 3P medicine worldwide, and also within 3% of top journals in innovative medicine in category health policy. So we will talk about all these aspects during my presentation. What was the beginning of the EPMA? A little bit about our history. The association is created in 2008. And at that time, it was quite difficult discussion with all the professionals in ophthalmology, in radiology, in pediatrics, and so on. Why we need interdisciplinarity, why we need this multi-professional approach. Everybody is happy in their own element. So why we should go this difficult way to introduce a new concept and the paradigm change from reactive medicine to 3P medicine. So at that time, we were in Europe, we were in preparation of the program. You know, it is called Horizon 2020, and in 2011, EPMA has presented its concepts to the European Commission. What is our vision in medicine for the future? And can you imagine, so we have started the EPMA journal in 2010, and in 2011 at the roundtable discussion with the European Commission, we have presented also our journal, and all the issues disappeared within 1 hour. So our supervisor in Springer Nature, he said that it was really difficult to resist because people were so much interested in this, and the journal disappeared within 1 hour among the professionals. So the interest was huge, and all the concepts which EPMA has presented to the European Commission in Brussels were accepted for the new program Horizon 2020. It was our very successful start into promotion of our concepts within the scientific communities, within the international bodies, within the medical societies, and so on. What was the reason to do this? Please, next slide. I will present to you the so-called current global achievements by reactive medicine. This is what we would like to transform in the concepts of PPP medicine, to promote the paradigm change from reactive medicine to 3P medicine. Next slide, please. Why we are so much unhappy with the results of reactive medicine. On this slide, you see the pandemics, global pandemics of the cohort of diabetic patients. So for a long time, we believed that once this increasing tendency will reach its plateau, and it's done. Already in 2010, EPMA has presented the prognosis and predictive data, saying that no, dear colleagues, it will not work like this. We will not reach the plateau. It will increase in a dramatic way, and this was a publication in the EPMA journal already in 2010 with prediction of this pandemic trends in diabetic development. Next slide, please. So the current achievements by the global reactive medicine in diabetes care, unfortunately, are dramatic. So worldwide, we have already more than 500 million patients affected by diabetes, mainly diabetes type 2. In the prognosis that this pandemic situation will worse, is reaching more or less 750 million patients by 2040. Probably will be even worse, because currently about 30 till 50% of diabetics are still remaining undiagnosed. And what is even worse, that there are a lot of more or less 30% of the new diabetic cases are coming from teenagers. This is a dramatic development. It is also a big economical burden to the medical care worldwide. And the prognosis, so now we are facing about $515 billion only in USA, and globally it is expected more or less 10 trillion US dollars of economic burden in diabetic care globally in 2040. So at the beginning, you heard the address that it is fantastic to work with personalized medicine, but forget about personalized medicine with this number of patients. From economical point of view, it is not doable. So that's why it is not just a dream to change the paradigm from reactive medicine. It is the necessity. We will not manage it in medical care otherwise. So we have to be predictive, we have to be preventive, and we should promote the personalization to our patients, because as you see to the down layer of the slide, that every second one patient dies on diabetes mellitus related complications. This is the result of not personalized medicine worldwide. So next slide, please. Coming back to the topic of the conference, ophthalmology. So what I would like, my first message to you is that ophthalmologists are at the forefront of medical care today. If you see this slide, it is a so-called domino effect, for example, in diabetes care. If we oversee the first stages of complications, the whole cascade of pathologies will happen. And the very first indicator of this cascade are changes in retina. Why? Because retinal cells are extremely sensitive to stress and diabetes, fluctuation of glucose and other neuropeptides like insulin are extremely stressful to the whole body. So what we deal with are systemic effects in diabetes. And systemic effects you can first of all recognize with instruments of ophthalmology. So if we deal with early retinopathy, we will deal with the whole cascade of complications in diabetes. That's why my first message to you, please be active, proactive as experts in ophthalmology, treating systemic disorders. You are really on the forefront, and we people in 3P medicine, we really trust that we will be able to manage the problem together with you. Without you, without your expertise, it's very, very difficult to treat systemic disorders. So next slide, please. To be proactive, we need screening methodology. We need to be predictive. How to do? It's not simple, because it is like to look for a needle in a haystack, to look for people in suboptimal health. Suboptimal health means the transition from health to disease. How to protect them? How to do it cost effectively? It means to be predictive. And for this purpose, we need a lot of technologies. Next slide, please. However, already today we have a lot of technologies, and a lot of them, the majority of them, are extremely expensive. So what we would like to avoid is to be technology driven, that once we have a sophisticated technology, that we should immediately apply it to everybody. If I'm talking to my students in my course 3P medicine, I ask them, what would you like to apply to the population for screening? You know, the first idea, genomics, transcriptomics. Good methodology, but very expensive. So should we start immediately with sequencing people, or can we consider clever methodology which is personalized and which is cost effective in order to be predictive? Next slide, please. And indeed, those of you who are working daily with patients, you know that personal contact to patient is extremely important. And this is not the most expensive methodology. First, to talk to people and to apply your knowledge accumulated in terms of phenotyping. What is phenotyping? Look at this Shrek. You know, everybody knows from animation films, no? Shrek, XXL, phenotype. What does it mean for experienced medical doctors? It means obesity. It means predisposition to diabetes type 2. It means strong predisposition to cardiovascular disorders. In 60% of diabetics, to retinopathy, to cascading pathologies, including chronic inflammation, impaired wound healing. And you know from innovative research that both these factors, chronic inflammation and impaired wound healing, means very aggressive cancer disorders. Consider that, for example, with us in Bonn, Excellence University of Bonn, in gynecology, the full floor is dedicated to patients with endometrium carcinoma. Prior to operate them, blood investigation is done. And what is coming out? That majority of these women already established diabetes type 2. So it means that we start care at the secondary level. So we have overseen the phenotype, obesity. We have overseen diabetes type 2. We have overseen impaired wound healing. We have overseen chronic inflammation. And as soon as it is progressing cancer, we start to treat the patient. This is a result of reactive medicine, which we would like to reconsider, coming back to suboptimal health, protection against health to disease transition, to primary care, to 3P medicine. Next slide, please. Phenotyping. So ladies who going for shopping, you see that the size, middle size, is almost disappearing, and that we now facing more phenotyping like XXL and XXS. So these are two extreme cases, and if we said that XXL was the predisposition to diabetes, it is these are people with obesity and cascading complications. The question is, come please to previous slide. This is important to emphasize. To be very slim, does it mean to be very healthy? Let us try to answer to this question, because this is very important message to our young populations, you know, because we said, you know, if you will not be obese, if you reduce your weight, you will be more healthy. This is the message which we frequently receive from cardiologists. So really, let us try to answer the question, if you are very slim, are you very healthy? It is the opposite phenotype, XXS. Next slide, please. In 2018, this was a grandiose publication released by Lancet Diabetes Endocrinology. People had investigated 3.6 million patients died from different reasons. And they have analyzed the correlation with body mass index. You know, and you see here the level, the risk of mortality for different disorders, including cancer, neurological disorders, and so on. And you see that the lowest risk to die among these 3.6 million analyzed cases was about 25 body mass index. So to the left side, it is XXS. Barbie case, and to the right, it is Shrek, very high body mass index. So it means that to be very slim is not a good idea. So we should really correct our colleagues from cardiology saying, reduce your weight, reduce your weight. The weight body mass index is extremely individual, and this should be kept in mind. And this should be kept in mind together with all other features belonging to the individualized patient profile. But coming back again to low body mass index, look at these problems, what they have in this population: anorexia nervosa, depression, impaired wound healing, decreased immune barrier, decreased reproductive function, decreased survival in cancer patients, and so on and so on. But what is probably the most important are the reduced mitochondrial health in these people. And what is very, very important for your symposium today is primary vascular dysregulation. Next slide, please. So they published by our colleague in Basel, more or less 20 years ago. Next slide, please. Yes. They have demonstrated that primary vascular dysregulation is extremely important predictor and very important factor, risk factor for normal tension glaucoma. Why? So here you see the nail fold capillary microscopy, and on the left side, this is the normal blood stream in fingers under microscope. And under stress condition, and stress, if we say stress, it means it could be cold provocation, it could be emotion stress, and so on. The bloodstream is inhibited. Within this more or less 20 vessels, you see that the functional are not more than 1 or 2. What does it mean? It means necrosis, apoptosis. Low blood flow is very, very important indicator, which is considered in many disorders. But for you guys in top ophthalmology, I think that this is a very, very important indicator to be considered, particularly for prediction of the development of normal tension glaucoma among young people. So we know a lot of cases of very young people, 30 plus, who develop normal tension glaucoma. Very difficult to treat. There is a lot of disputes around how to do, because you know that with high tension glaucoma, it is better established approach. With normal tension glaucoma is very difficult. And this is really to draw your attention to the fact that to treat normal tension glaucoma, you need really a multidisciplinary approach. You need consultation of general practitioners who work with young people with family predisposition. You know that there is also a genetic predisposition to normal tension glaucoma. So there are many, many, many factors contributing to these disorders. And besides the genetic predisposition, all other factors are predictable and preventable. It means that if we will apply 3EP medicine early enough in the population of people at risk to normal tension glaucoma, we have a very, very good chance to succeed. Next slide, please. Again, to the point, genetic component. The question about normal tension glaucoma, is it purely genetic nature of the risks? you know, in January 2000, I think that it was 2015, yes, exactly. The President of United States, Mr. Obama, has announced the new program run by USA in terms of precision medicine. And the main tool, what they have proposed is genetic predisposition. What does it mean concretely? Sequencing of the population. Sequencing of the population, 350 million of US population, is not simple to verify the hypothesis that this is the good tool to keep the population healthy. There are small countries in the world, like, for example, Iceland. Next slide, please. And the representative of EPMA in Iceland is one of the well-acknowledged top experts in cardiovascular disorders. And after the Americans have proposed this program of precision medicine and sequencing of the population, they said, okay, America is very big. It will take years and years to see whether the approach works. We are 250,000 in Iceland. Let us check whether the approach works, just to sequence the population and try to interpret the data. Again, our representative there is the top expert in cardiovascular disorders. And indeed, in 3 years, they have dedicated good budget and they have sequenced the entire population of Iceland, trying to correlate the sequence data, DNA sequencing data, with appearance and severity of cardiovascular disorders. And after this huge project, they came to the conclusion there is no interpretation of the data. There is no direct correlation between sequencing data and appearance and severity of cardiovascular disorders in the entire population of Iceland. Next slide, please. It means for us, the message to everybody, the genetic component, yes, very important, but it is not the whole story. There are many other risk factors which are contributing to the final clinical manifestation of the disorders, including lifestyle, modifiable risk factors, environment, modifiable risks. You remember probably some years ago, it was the broad discussion about the case Angelina Jolie. Her grandmother suffered from breast cancer, your mother suffered from breast cancer, and Angelina Jolie said, okay, I understood the message. It is our genetic predisposition. The breast should be removed. Aesthetic medicine should reconstruct the breast, and I'm cured forever. There was a very, very big discussion around this case. So yes, it was the personal decision of Angelina Jolie. But should we offer this approach to everybody, to young girls, 18 years old, with BRCA1 and 2 mutations in genes? The probability that they will receive the diagnosis breast cancer is about 60%. Can you convince 18 years old girl that her breast should be removed because of this genetic risk? Or should we implement the entire predictive approach of 3P medicine? Sorry. To work on other risk factors like environmental risks, lifestyle, and to reduce individual risk to a minimum? Is it not more cost-effective? Is it not more ethical approach? Question to you. Next slide, please. So we in EPMA, we consider this approach more ethical, more cost-effective, and more future-oriented. So that's why the paradigm change we have proposed and we promoted worldwide with scientific communities, with medical doctors, with patient organization, with political organization, namely that instead of to apply disease care, and you see it on the left side, we should apply the advanced healthcare. It means to be proactive, to act within the upper layer, utilizing the predictive approach, and don't go within the down layer. You see the already manifested, clinically manifested disorders. So really to be proactive, to apply the predictive medical approach. It means health risk assessment, genetic component, lifestyle, individualized patient reports, in order to help people to remain healthy mentally and physically. I see the next slide. Thank you very much for this. So it is the slogan, probably you will support me with this. You cannot manage if you cannot measure. So this is very, very important. During our Congress in China in September, we have discussed the PPPM with a lot of experts, including acupuncture, traditional Chinese medicine, ancient medicine, and so on. Chinese colleagues were excited about 3 p.m. saying that this is exactly our philosophy. This is exactly our philosophy, to be predictive, to prevent the disorder before the clinical manifestation, like, for example, cancer disorders or eye disorders. So, but we should work together because in traditional Chinese medicine, acupuncture, for example, so the approach is running according to a subjective feeling. How do you feel? And after acupuncture, how do you feel? You know, this is very important, this emotion feedback from the patient. But besides that, what we need to objectively measure the results prior to application of any treatment, during, to see the individualized reaction towards the treatment, and afterwards what we have reached with our treatments. So that's why this complex approach, what do you see now on your next slide? Namely, the combination, this is the innovation of the approach, combination of phenotyping and genotyping to predict individualized outcomes and to perform cost-effective screening in the population. This has been published in many books released by EPMA. Next slide, please. So what we propose concretely, companion diagnostics, for example. It is very, very important for primary care and secondary care. Primary care, it means the protection of individuals against health to disease transition within the phase of reversible damage. This is very, very important because many patients which at the end established normal tension glaucoma were predisposed to this disease due to suboptimal health. And if we will be able to recognize risks early enough, our approach will be cost-effective and ethical. Secondary care, the pathology is already established. For example, diabetes care, but it is not the fact that the disease should progress further. And this is our obligation in 3P medicine, in multi-professional networks, to protect our patient against the disease progression, and it is possible. That's why this companion diagnostic, very comprehensive. I would like to ask you for the next slide, please. You know that among our patients, there are two main categories. One category, they don't go to doctor because they don't want to receive bad news, and they try to avoid this contact. You know, I'm talking to my Indian students who are coming from South India in Kerala, and you know that Kerala is the capital of diabetes worldwide. 10 years ago, there were every third family affected by diabetes. Now there is each family in Kerala is affected by diabetes. And I ask them, what is the reason? Because as Chinese colleagues, also Indian colleagues are very, very effective, were thousands of years very effective, for example, with Ayurveda. What happened to your medicine? And they said that bad lifestyle, hamburger, fast food, too much stress, and people don't go to doctors. You know, they in general, they don't have enough money to go to ophthalmologist as a diabetic patient to check the eyes. They wait and wait till they are blind. This is the problem. This is one part of the population. Another part of the population, they go to the doctor every day. You know, for example, they have established problems, cardiovascular problems, and they want to be sure that nothing will happen today. So they go today, they go to tomorrow to the doctor. And the solution for both parts is this digital health. And this is what you see, the smart devices to measure every day at home risk factors. So this is really a very strong innovation to make our patients sure that everything is okay, that everything is stable, and also to make us doctors sure that the disorder is stable, or even if they are in suboptimal health, that they improve their health status. So this is a real innovation and belong to the future in medicine. Next slide, please. So what we have achieved till now, you know, a lot of slogans, a lot of recommendations in PPPM, but nevertheless, look, we started in 2008. The association is registered in 2009, and in 2008, if you go to PubMed at Predictive, Preventive, Personalized Medicine, you see 10 publications altogether around the world, released by experts belonging to EPMA, and now this exponential growth of number of articles in the world. So this is a big achievement. It is a big recognition. People start to understand what does it mean, EPMA. They start to understand that the paradigm change from reactive medicine to 3P medicine is unavoidable. This is the future, and we should follow this progress. Next slide, please. As I told you, we try to be very multi-professional. So we work with all professionals in medicine, with patient organization, with scientists, and so on. But we also are in a very good and a tight relationship with international organizations like United Nations. So the first meeting was in 2011. We met together, the highest representative of United Nations in Geneva, the president of the European Medical Association, with 50,000 doctors around Europe who work with us because they are a group of professionals who supposed to implement the innovation promoted by the EPMA. And the next slide. this is very important, and I would like to read this letter of United Nations to EPMA, exactly that you know what are the contents and what is the support which we receive by international organizations. So Organization of United Nations places emphasis on advances in medical research, training, and care as the key to realizing the Millennium Development Goals and to advancing public health. Further, United Nations values EPMA efforts in contributing to developments in the medical field towards our common goals of improving the healthcare, and doesn't doubt that EPMA will serve as a strong platform for medical innovation in support of our shared objectives. The Vice Secretary General of United Nations Organization welcomes in particular the focus on collaboration with international organizations we can serve to link the work of the EPMA with the effort of the international community for global public health. So what are our instruments to realize these Millennium Goals in cooperation with other multi-professional groups? First of all, our global conferences and congresses. As already has been mentioned, in September 2024, 2 months ago, there was a huge congress in China. It was already the 7th EPMA Global Congress in the world. More than 5,000 participants, huge interest from 35 countries participated to this event. Very, very important. We are very transparent at the organization. So we publish all the achievements, all the prognosis, all the strategies around the world, together 56 countries, and the transparency is also thanks to the EPMA journal, which is the global leader in the world for 3P medicine and one of the leaders in health policy. Next slide, please. The EPMA works generally with very clear structures, like national committees. And Professor Kulisheva is one of the most active members of the Russian National EPMA Committee, contributing a lot. Probably you have seen her publication released in 2023, which is very well cited. Very important innovation in management of glaucoma, including risk factors, individualized patient profile, and artificial intelligence. Very clear message for the future in developments in the area. Thank you very much to your great efforts. We really appreciate your contribution, your ideas, your creation in the area. This is very, very important, and I wish your conference a lot of success. You are very, very important for 3P medicine. Ophthalmology is on the forefront of 3PM concepts, and I would like to invite you to consolidate your efforts, and in 3 years the next huge congress of EPMA will take place in Middle Asia. We expect it to be, but it should be also supported by all members of EPMA. So now it is in discussion, but with 99% it will be in Samarkand. So see you in 3 years, and I really trust in your support to Professor Kulisheva, to 3PMA concept, and I really trust in our tight collaboration. Thank you very much for your attention.